A very good evening to all of you. The topic for the day for me is biarticular muscle length assessment in spastic cerebral palsy. I must say this is a total practical topic. I don't know how much justice I will do with this theoretical presentation, but still I'll try my best so that I can justify the practical aspect of this particular topic with the help of this presentation and the subsequent videos which will be demonstrating the tests which are involved in the assessment of these biarticular muscle length in cerebral palsy children. We know there are various types of cerebral palsy. Depending upon the muscle picture, it can be spastic, it can be flaccid, it can be ataxic, or it can be athetoid and mixed variant. It is the spastic variant of cerebral palsy which usually requires orthopedic intervention before the skeletal maturity or even after that. When it comes to the topographical classification, we know that there are various types of cerebral palsy such as hemiplegic children with diplegia, quadriplegia, monoplegia, etc. We know that standing potential and the walking potential is maximum with the children with hemiplegia and the diplegia variant. So whenever as a therapist you are treating and assessing such children, those who are expected to undergo surgical intervention in near future, the detailed assessment of these biarticular muscle will be important. What do we mean by biarticular muscles? Muscles, depending upon how many joints they are crossing, it can be the biarticular or monoarticular. Obviously, a monoarticular muscle crossing only one joint, whereas the biarticular muscle, they cross two joints before their respective point of insertion. While performing two different functions at two different joints, the biarticular muscles are vulnerable not only for injuries but also for significant functional limitation as in conditions like cerebral palsy. Remember, it's not only the cerebral palsy. Assessment of the length of these muscles will also be important for other conditions such as sports injuries. We know gastrocnemius sprain, that is called as tennis leg, or injury to the rectus femoris, which is quite common among footballers. Again, the assessment of these muscle length will be important. Spastic cerebral palsy children usually encounter such functional limitation caused by spastic and tight biarticular muscles during the act of locomotion. Because spastic variant of cerebral palsy is also known as the short muscle disease. The diplegic spastic variant of cerebral palsy, also known as Little's disease, have better standing and walking potential than the other variants of cerebral palsy, particularly the quadriplegic one. Early surgical intervention is advocated with the aim of prevention of liver arm disorder in such children. What is liver arm disorder? This is nothing but some of the adverse harmful effect of the spastic muscle over the immature growing skeletal system. They include hip joint subluxation dislocation, coxa vara or coxa valga, hindfoot valgus, and talonavicular break. Prevention of these structural liver arm disorder will be possible only in presence of early intervention in form of correction of these biarticular muscle tightness. The identification of problem muscle is important in all such cases, whether they are treated conservatively or operatively. What is the effect of spasticity on growing muscle? Spasticity causes tightness and contracture of muscle and other periarticular structures such as capsule, which subsequently may lead to joint and bone deformities. Remember, it's always easy to treat soft tissues rather than treating a joint or a bone for correction of deformities. The compromised length of muscle leads to poor voluntary control over the movements, which is always an important concern of physical therapists dealing with cerebral palsy children. The effect of compromise in the length of muscle is mostly significantly observed in biarticular muscle, which requires special attention during the therapy. Commonly affected lower limb biarticular muscle in a child with cerebral palsy diplegic variants will be psoas major, rectus femoris, hamstring, gracilis, and gastrocnemius. This is the picture which is showing the psoas major, the rectus femoris, the hamstring, and the gastrocnemius. These are the commonly involved biarticular muscles in spastic cerebral palsy diplegic variant children. Why it is important to identify the problem muscle? It's always good to know the problem. If you know which muscle is troubling, it will be easy to treat it. It will be easy to avoid mistakes. For example, if surgeon is performing hamstring lengthening in presence of a tight rectus femoris, it can result in development of genu recurvatum. Hamstring lengthening will not help a child with a tight gracilis. Tendo Achilles lengthening is not going to help if the component is from the gastrocnemius. It is the gastrocnemius which should be resected rather than tendo Achilles. So such condition will be important to understand before the intervention. The assessment of biarticular muscle length, there are certain basic things which must be remembered. Number one, it will be the combination of movement. We know the biarticular muscle crossing the two joints must be performing two different functions. While stretching these biarticular muscle, a combination of movement will be required. While performing these combined movement, always try to observe both the joints at a time. We have to basically check for the passive insufficiency in the length of muscle. Stabilization will be important along with prevention of any compensation. For example, whenever we are checking for the length of hamstring, usually we perform straight leg raise, a passive straight leg raise. That is maintaining the knee joint in full extension and performing hip flexion. While doing so, if the pelvis is not stabilized properly, it can result into posterior tilting of pelvis. And then it will result into a false increase in the range of hip flexion, which must be prevented. So I'm going ahead with the first muscle, that is psoas major. I'll try to demonstrate the test through the video at the end of the lecture. But before going for the demonstration, let's understand the theoretical aspect of psoas major and assessment. Psoas major getting origin from the lumbar spine, merging with the iliacus, getting inserted at the lesser trochanter, which is a strong hip flexor. But whenever we are in closed chain, that is, distal part will be fixed. At the time, the reverse pull of the psoas major can result in increase in the lumbar lordosis. And the same thing is expected in a child with cerebral palsy having tight hip flexors. With a tight hip flexor, the child will manage to stand with near normal neutral hip joint, but at the cost of exaggerated lumbar lordosis. That means hip flexion deformity and lumbar lordosis are going hand by hand. It is the Thomas test which helps us to detect the tightness of hip flexors. While performing Thomas test, first of all, bring the child to the edge of examination couch. You might need the help of the parents to stabilize the opposite knee joint in flex position, maintaining hip flexion and knee flexion. Remember not to overpress to get extra range of hip flexion because it can result into a false positive result. Insert your one hand, preferably the cranial hand, over the lumbar spine. This hand will palpate or will keep a check over the appearance or the disappearance of lumbar lordosis. Remember, bring down the test limb gradually into neutral position. If before reaching the neutral position, if the lumbar lordosis reappears, it indicates tight hip flexors, or if the hip is unable to reach the neutral position, it is indicating tight hip flexors. The must be measured through this. One arm, that is movable arm, will be parallel to the shaft of femur, and the fixed arm will be parallel to the examination couch. The fulcrum will be somewhere around greater trochanter. This is the angle of hip flexion deformity, a positive Thomas test. The next muscle is rectus femoris. It's a two joint muscle crossing hip joint as a hip flexor, crossing the knee joint as a knee extensor. It's also known as the kicking muscle. While assessing the length of rectus femoris, put the patient in prone lying. Putting the patient in prone lying will put the hip joint in relative extension. We know the rectus femoris, which is a flexor of the hip joint and an extensor of the knee joint. When the patient is lying prone, the hip flexor component gets stretched. If the rectus femoris is tight and we attempt passive knee flexion in prone lying, the pelvis will be lifted upward, or you won't be able to complete the range of knee flexion, indicating tight rectus femoris and a positive Duncan ELY'S test. The third muscle is gracilis. We should know that the medial compartment of thigh is poorly separated with the posterior compartment of thigh. The medial compartment, which basically includes the short and long adductors. The short adductor includes adductor magnus, longus and the brevis. These are one joint muscle crossing the hip joint, acting as hip adductor. But the gracilis is a two joint long adductor crossing the hip joint as hip adductor and the knee joint as a weak knee flexor. In order to assess the length of gracilis, we have to check for the range of hip abduction with the help of abduction spread. This abduction spread should be done in two different situations, with the knee in flex position and with the knee in fully extended position. If the range of hip abduction is less with the knee in flex position, it indicates possibilities of tightness of the short adductor, that is adductor magnus, longus or the brevis. But if the range is near normal with knee in flexion and reduces, the range of abduction reduces when we attempt hip abduction spread with knee in full extension, it will indicate the gracilis tightness. Remember, the basic of modified Phelps gracilis test is the difference between the range of abduction with knee in full extension or with knee in flexion. Fourth muscle is the hamstring group of muscle. Out of the three major muscles, the lateral hamstring and the medial hamstring. The biceps femoris gets inserted at the fibular head and the semitendinosus and semimembranosus over the tibia. Whenever the hamstring, which is a secondary hip extensor and a primary knee flexor, is tight, it will result into reduction in the range of hip flexion with knee in extension. This is called as range of straight leg raise. This is a passive test. Make sure the contralateral limb is maintained in neutral position. The therapist will stabilize the knee joint in full extension and go for passive hip flexion. Normally, the range of hip flexion with the knee in full extension is around 70 to 90, depending upon the flexibility of hamstring. While doing so, always keep a check over the posterior pelvic tilting of the pelvis. because in case of absence of stabilization of pelvis, the pelvis may tilt backward or posteriorly to give a false increase in the range of hip flexion. The second test which can be used for assessing the spastic compromise in the length of hamstring is popliteal angle test. It is a velocity dependent test. We know the spastic muscle respond to sudden stretch. While performing this test, the child should be kept in supine lying with the hip joint in 90-degree position. Knee will be thrust into sudden extension by the examiner. This will put a stretch over the hamstring group of muscle. If they are spastic, they will immediately contract to restrict the range of knee extension. Normal range of popliteal angle is less than 30 degree. An increase in the popliteal angle indicates possibilities of spastic tightness and contracture of hamstring muscle. While assessing hamstring, if we want to differentiate between the medial hamstring and lateral hamstring, the same test can be performed with hip joint in internal rotation for medial hamstring and hip joint with external rotation for lateral hamstring. The last muscle is gastrocnemius, which is a strong plantar flexor, but because it is crossing the knee joint posteriorly, originating from the medial and lateral femoral condyle, it also acts as a weak knee flexor. It merges with the soleus to form the tendon to Achilles, which gets inserted at the posterior tubercle of calcaneum. This picture is explaining the length of gastrocnemius. When the knee is in full extension, the maximum stretch will be at gastrocnemius. If the knee is flexed, the stretch over the gastrocnemius will be reduced. Soleus being a one joint muscle, it has nothing to do with the position of knee joint. The test which is used to differentiate the tightness of the gastrocnemius muscle and the tightness of tendoachilles muscle tendon is Silverskiold test. This is a very simple test where the therapist will check for the range of passive dorsiflexion while maintaining the knee in full extension and with the knee in flex position. Any significant increase in the range of dorsiflexion when the knee is kept in flex position indicates the involvement of gastrocnemius muscle. If gastrocnemius is involved, it's better to treat gastrocnemius rather than the tendoachilles. So the choice of treatment can be gastrocnemius resection. This is the theoretical aspect of biarticular muscle assessment in spastic cerebral palsy children. I'll try to demonstrate each possible test in the subsequent section of this presentation through videos. Thank you. Hello everyone. So we are here to go ahead with the demonstration of the biarticular muscle assessment in cerebral palsy cases. जैसा हमने presentation में देखा था, there are biarticular muscle which needs specific tests and assessments to check their length. The first muscle which I am going to demonstrate is the hip flexor, the Swartz measure. Swartz measure के assessment के लिए जो test use किया जाता है, that is called as Thomas test. She is my daughter. She will be helping me for the assessment protocol. For Thomas test, the first thing to do is make the patient sit at the edge of examination table. Now, with support, tell the patient to lie down flat and bring the pelvis at the edge of examination couch. Come down. Request the patient to hold the non-test limb with the upper limb. If the cerebral palsy children is not able to do so, you can request the parent to do the same thing. Now, you will be using your cranial hand to put it under the lumbar spine. Your cranial hand will basically palpate the lumbar spine for a appearance or the disappearance. We know whenever we are performing bilateral hip knee flexion, it will result into posterior pelvic tilt and flattening of the lumbar lordosis, which is expected. Tell the patient to hold the non-test limb in 120 degree of hip flexion. Now, gradually bring the test limb into neutral position. While doing so, you have to keep in mind two things. Number one, check at the point where the lumbar lordosis is reappearing, or check the range of hip flexion at which the flexion range will be stopped. So, while performing the test, bring it down and check for the range of hip flexion. Normally, the hip should come till the neutral. If it is not coming and getting held at certain angle, measure the angle, the shaft of femur and the imaginary line corresponding to the couch. That is the angle of hip flexion deformity. Kuch precautions hai. Number one, never go for too much of flexion of the contralateral limb, because that will result into too much of posterior pelvic tilt and a false positive result. Added to information hai. Number one, if in case while performing Thomas test the knee goes into extension, that is indicating the possible tightness of rectus femoris. If while performing Thomas test the hip joint changes the plane from a sagittal plane, if it shifts towards the abduction, that is in frontal plane, it is suggesting the possible tightness of iliotibial band. So that is the detail related to Thomas test. Thank you. Test for the biarticular assessment in cerebral palsy children is prone rectus test, also known as prone DUNCAN-ELY'S rectus tightness test. To perform this test, first of all, request the patient to lie down prone. Remember, lying prone will put your hip flexors at a stretch, whether it is psoas major, whether it is iliacus, or whether it is rectus femoris. So the hip flexor component of the rectus femoris will be kept at a stretch if the patient is lying prone lying. Number two, in order to complete the test, perform a passive knee flexion for the patient. While performing so, normally the heel should be able to touch the buttocks. But if the rectus femoris, which is a two-joint muscle acting as a hip flexor and a knee extensor, if it is tight, what will happen? Whenever you go for a passive flexion of the knee joint in prone lying, the pelvis will be lifted up. This is called as a positive DUNCAN-ELY'S prone rectus test, indicating the tightness of the rectus femoris. Thank you. In the series, the third test which we are using is to differentiate the short adductors of hip joint with the long adductors of the hip joint. Short adductors, which includes adductor magnus, adductor longus and adductor brevis, and the long adductor include the gracilis muscle along with the medial hamstring. Now, whenever we are talking about checking the length of adductor muscle, obviously we have to go for abduction of the hip joint. The only thing to keep in mind, whenever you are doing abduction of the hip joint with knee in flex position, that means you are stretching the adductors, the short one. Whenever the knee is maintained in full extension, you are stretching the adductors of hip, long one. Okay? So while performing the differentiating test for adductors short and adductor long, we have to perform abduction spread. Bring the hip joint into fully abducted position and check for the range of hip abduction. Now, same thing, while performing the test, request the parent or someone to hold the contralateral limb in neutral position and now go for hip abduction. The normal range of hip abduction is 45 degree. Any restriction in this range of motion is indicating the possibilities of tightness of the gracilic muscle. How to differentiate the gracilis muscle tightness with the short adductor tightness? There are certain options. Number one, the base of support. Whenever we are standing obviously the gracilis will be also tight, and if it is restricting the adduction, the abduction range, standing base of support will be less as compared to kneeling base of support. When you are kneeling down, obviously the knee is in flex position, the gracilis will not be coming into picture. If the short adductors are tight, the base of support will be small in case of kneeling as well as in standing. But if it is gracilis, only the standing base of support will be less as compared to the kneeling base of support, which will be near normal. So, the modified Phelps gracilis test. While doing so, you have to stabilize the other one, because there is nobody here to help me out. I will consider this one is stabilized. Now, while performing the test, first of all, go for maximum amount of hip abduction on the test plate. Now, while maintaining the abduction and the knee joint in flex position, gradually go for extension of the knee joint. She is having a good length of the gracilis muscle, that is why I am able to do so while maintaining the hip abduction range. If the gracilis is tight, what will happen? While performing the test, I won't be able to complete the knee extension because the gracilis will be tight. Gracilis is acting, number one, as a long adductor and the flexor of the knee joint. So it will not allow full extension of the knee joint. Or else, if I will be able to do so, there will be a tendency of hip joint to move towards adduction. This will confirm the possibilities of Phelps gracilis positive test. There are other methods also, like lying down prone, maintaining the maximum amount of abduction while keeping the knee in full extension. Now perform knee flexion. If you get additional range of abduction, that is again suggesting a positive gracilis test. We can call it modified Phelps gracilis test. Thank you. Which comes in the category of biarticular muscle involved in cerebral palsy children is hamstring group of muscles. Hamstring, which is a secondary hip extensor apart from the gluteus maximus, and a primary knee flexor. This two joint muscle is commonly involved in cases of cerebral palsy. One of the simplest method to assess the length or any compromise in the length of hamstring muscle is to check for the range of straight leg raise movement. Straight leg raise, that is hip flexion while maintaining the knee joint in full extension. To perform this test, you have to request someone to stabilize the knee joint so that the pelvis remains stable. Remember, whenever we are performing hip flexion, we have to check for the length of hamstring. Obviously, the hip joint component of hamstring will be stretched and knee joint component will also be stretched because the knee is maintained in full extension. You have to check for the available range of hip flexion. You can see here, while performing so, the other limb is getting lifted. So in order to prevent this, you have to stabilize with the help of a passive support, a therapist or the parents. Now, while doing so, you have to always keep in mind, it should not be a forcible movement which will allow posterior pelvic tilt. One of the basic reasons why we are keeping the other limb into full extension is to lock the pelvis. This side, pelvis will be stabilized in neutral and I am performing hip flexion on the contralateral side. Obviously, beyond the available range, there will be a posterior pelvic tilting component, okay, which must be checked. So while doing the assessment, you always try to keep a watch over the pelvis. If it is going into posterior pelvic tilt, you might find it an awkward result of hip flexion beyond normal side. So normally, while performing so, stabilize the contralateral limb and check for the available range of hip flexion, maintaining the knee joint in full extension. This is SLR range. Thank you. So the final test which will be used for assessment of biarticular muscle in cerebral palsy children is the SILVERSKIOLD test. This test is basically designed to rule out the tightness or contracture of tendoachilles and differentiating it with the tightness of the gastrocnemius muscle. It's not always the tendoachilles. Sometimes even the gastrocnemius can be a primary culprit to cause equinus. And while doing so, अगर हम टेंडो एक्लीज को ओवर स्ट्रेच कर दें और टेंडो एक्लीज को ऑपरेट कर दिया जाए तो इट विल रिजल्ट इनटू some reversal of deformities and loss of stabilization of the knee joint, which is basically done by the plantar flexor muscles. So it's again important to differentiate whether the equinus is being produced by tendo Achilles contracture or it is only caused by the gastrocnemius. While performing the Silverskiold test, you will check for the range of ankle dorsiflexion. The ankle dorsiflexion range has to be checked with knee joint in full extension. Don't go for hyperextension. Okay, so maintain the knee joint in neutral position and check for the range of ankle dorsiflexion. Even normally, whenever we perform dorsiflexion with the knee joint in flex position, we can expect greater range of dorsiflexion. The same thing is applicable for Silverskiold test. Go for ankle dorsiflexion with the knee in neutral position. And now repeat giving overpressure to the ankle joint while maintaining the knee in flex position. If there is no difference in ankle dorsiflexion range, whether the knee is in extension or flexion, that means the primary culprit is tendo Achilles. But if the range of dorsiflexion is less with knee in full extension, which increases significantly when we are going for knee flexion, it is the gastrocnemius which is responsible for equinus. So the treatment will be stretching of gastrocnemius rather than tendo Achilles. Okay? Thank you. Which is used widely for assessment of the spastic tightness or contracture of the hamstring muscle is popliteal angle test. Remember, this is a velocity dependent test. Okay, so certain movement has to be performed quickly so that the spastic muscle will be subjected to a sudden stretch. We know spasticity हमेशा रिस्पॉन्ड करती है वेलोसिटी को. Whenever we apply a sudden stretch over the spastic muscle, it will respond by contracting. That is the basic ideology behind popliteal angle test. To perform the test, tell someone to stabilize the knee joint on the contralateral side. Now, the test length should be maintained with hip joint in 90-degree flexion. Patient totally relax. The therapist's cranial hand will be holding the tibia. Okay, and now you have to apply a sudden thrust in extension. This sudden thrust is going to put a stretch over the hamstring muscle, somewhat like this. Okay, a sudden movement is required. Whenever we are performing this sudden movement, it will result into a sudden stretch over the hamstring muscle, and if it is spastic, if it is tight, it will respond by contracting. Now, what has to be measured is this angle. This is the shaft of femur continued as a longitudinal line, and this is the shaft of tibia. The angle thus formed is called as popliteal angle. The normal range for popliteal angle is around 30 degree. Anything more than that is indicating the tightness or the contracture or shortening of the hamstring group of muscle. While performing the popliteal angle test, you can check specifically for the length of medial hamstring, that is semitendinosus and semimembranosus, or the length of lateral hamstring, that is biceps femoris. Only variation will be hip rotation. Go for the same test like popliteal angle. Go for internal rotation of the hip joint and go for a sudden thrust. This will put maximum stress over the medial hamstring. Now, same test when we perform with hip joint in external rotation, this sudden stretch is going to put maximum stress over the lateral hamstring. The interpretation is same what is applicable for a normal popliteal angle test. Thank you.